something, I'll try to keep an eye out for that in this Zoom world of ours.
And it looks like Travis just joined, so good.
Okay, well, let's get going. And then Michelle, we're kind of co-leading this, and so I think we'll just run a kind of a loose gavel here, and maybe I'll start off, and then you can just, you know, hop in with the privilege of the chair whenever you think it's a good idea. How does that sound?
Thank you. And Senator Abler, you just shut off your camera.
Oh, I didn't even touch anything. There I am. Okay. Anyway, well, welcome to who's ever here. I hope that we're going to have some in-person meetings soon, and I appreciate everybody who's borne with us through the interim time. I'd like to call the meeting to order. We have, if you wonder what a finance, I didn't touch anything, I swear. So if you wonder what a finance committee does, I'm not even touching my computer. If we talk about math, and today is like the math day of so many topics and so important, looking at the budget, and there's really a good plethora of topics we're going to cover. For my side of the committee, this is the only meeting I'm planning to have this year, unless something comes up. That may not be true for Senator Benson's committee. And so we put a bunch of stuff in here, and then we decided to make it joint. But I think that, and if it goes, we're trying to get done by noon or so, but if it goes a little long, then it's better than having to come back for a separate meeting or taking a lunch break. I was going to bring virtual snacks, but I didn't know how to make that quite work. So just imagine that I've offered you a plate of donuts you can't get to. And anyway, so welcome everybody. Everybody's gotten the agenda. There is and quite a list of attachments to the hearing notice that you will have gotten. Foremost amongst them is this document here, which I have in black and white from my home printer. It's the Human Services Forecast bit, and whoever put this together, I just want to commend them for making it one of the most useful documents in the forecast that I've seen. It's got executive summaries of the different niches, some trends. It's about 40 pages. It is extremely useful. If all you ever read in the human services world and health MDH was this, you would be very much on track with stuff. And so if you're a novice at this topic, you must read it. If you've been around a long time, you'll still learn something. This is the base document we'll be working off of. And so kudos to whoever did that. They should get a raise. Probably not our budget though. And so, and then I understand that at 10:30, Commissioner Malcolm will be coming. And so I think that just to respect, you know, Commissioner Harpstead is with us a lot anyway, and she's going to hang around and have her own comments. But just because there's only a small slice of things that relate to her, I think whenever she shows up, within a minute or two, we'll just break away from whatever we're doing and go to their segment. And then if the Commissioner Harpstead will just continue to fill in the gaps after Commissioner Malcolm goes. I think that'd be great. And Jody, do you have to leave at some point too? Or are you going to be just kind of monitoring this along?
You said it might go longer. That could run into a time when I can't stay, but otherwise I'm fine.
Okay, well, good. I wanted to respect that. So anyway, so without further ado there, welcome to the committee, Mr. Greenman and Mr. Bunch. And so we're going to dissect as much of these as we have to and take questions from members. On the blue ribbon thing, I was thinking like 15 minutes start to finish. On the forecast, that'll take the time it takes. The maintenance effort topic is a very worthy one, just to make sure we understand that. It won't have to take terribly long, I don't think. The COVID funds, we'll see how many questions there are. There could be a lot of questions there, and we want to allow for that. And then the retention grants part shouldn't be tremendously long, but so we're just trying to get a lot of stuff in. And so, but members, if you have questions on anything between Brittany and me, and if I seem to not notice you, just speak up, because just given the technology and my personal capacity. So, Anyway, Mr. Greenman and Mr. Bunch, the floor is yours, and welcome to the committee.
Morning, Mr. Chair, Madam Chair, and the members of the committee. My name is Dave Greenman. I'm the Budget Director at the Department of Human Services, and I'm going to walk you through some of the key pieces of the November 2020 forecast this morning. And I think Mr. Bunch is going to talk about the Healthcare Access Fund piece of the forecast. One of the things to start with is I'm going to be working from what we call the nutshell. I provided a copy of it. It's also on pages 39 and 40 of the executive summary that Senator Abler was showing you. It's labeled November 2020 forecast changes in a nutshell. And while you're pulling that up, I'll just mention that when we talk about forecasted we're going to talk about as forecasted programs, and these are the programs where the legislature appropriates funds based on projected expenditures, based on eligibility and rate payments and utilization. These include our medical programs like medical assistance and Minnesota Care, and also our CD treatment programs, and then economic assistance programs like MFIP, the Child Care Assistance Program and North Star, and then also some smaller programs related to economic assistance as well. This forecast, what we're looking at when we look at this, the nutshell, is what we're doing is we're comparing projected expenditures, what we project we're going to spend right now, to what we had projected back in May when MMB put out the interim budget projections. One of the things, so that this really is reflecting changes between now and back in what we thought we were going to spend back in May. One of the things I'd point out is when we did the May interim budget projections, we only had March data to work from. So with this COVID pandemic, we really didn't have much experience to work from in terms of trying to figure out how this was going to impact our forecasted programs. And so we've learned a lot since then. So to get us started, the net general fund impact of the changes to DHS's forecasted programs is a reduced projected expenditures of $919 million in fiscal years 20 and 21, and a reduction of $257 million in fiscal years 22 and 23. Almost 90% of that, of those reductions in 2021 result from three main adjustments that we made since the May interim budget projections, and virtually all of the changes result from those same three factors. And so I'll walk through those first. The first item is an adjustment. The first adjustment is an extension to the public health emergency, the projected length of the public health emergency. We extended it back in May. We assumed it would end in January. At this point, where we've adopted MMB's position that it's going to, from their forecast, which is it's going to last from January 1 through June, or it's going to last until June of 2021, which adds another 6 months of the public health emergency. And that's significant because the state receives, under the CARES Act that passed by Congress, the state receives an additional federal share on its medical assistance program. We call it the FMAP. It's Federal Medical Assistance Percentage of 6.2%. And so when the feds, obviously when the feds pick up a bigger share of the cost, the state picks up less of a share of the cost. And so there's a dollar for dollar replacement of general fund expenditures with federal dollars as a result of the 6-month extension. In order to get this extension, we are required to adopt policies that maintain continuous coverage or meet federal requirements for continuous coverage for medical assistance. And so there's some offsetting costs to that as a result of the in order to qualify for the FMAP. So the total additional federal share results in savings of about $337 million in 2021. That's offset by a cost of about $27 million for the continuous coverage provisions, and those were all adopted through the commissioner's executive order authority through waivers that we.
Thanks,
that
Mr.
were
Neiman.
adopted.
There's a question, but I have just a quick one. When you talk about assuming the federal, or about the continuation of the emergency, that's a federal level continuation. Is that right?
That's correct.
Okay. I think Senator Benson had a question.
And that was I wanted a clarification. The only requirement of the state to continue to receive FMAP is the maintenance of effort. I call it maintenance of effort. And can you help define, so we don't need to have an emergency declaration to do that, but can you define maintenance of effort a little bit more clearly, what those requirements are? Because I understand that optional coverages do not apply. So I understand there's some criteria that can be altered.
Mr. Greenman.
Madam Chair, Mr. Chair, there is federal requirement there are, as you said, there are specific things that we can't do or that we can't change. Like we can't we can't start disenrolling people from the program. And we have to, I believe we also have to maintain certain levels of care for people in long-term care. I'm trying to think of what other pieces there are. I don't, off the top of my head, I'd have to do a little bit more searching, but I can certainly get back to you with more details about what that all includes. I know that some of the feds recently issued some guidance to us that sort of put more nuance into what exactly it is we have to do. And so I can provide some of that, more of that detail to you as well.
Thank you. And Mr. Chair and Mr. Agreement, I see that Matt Anderson has unmuted.
Oh, great.
A couple of suggestions here. If we could have the department send to both of the finance committee chairs the guidance that has been sent around this so that we have a clear understanding as we're trying to build a budget going forward. And then Mr. Chair, I know it's an indulgence and we have a broad agenda, but if Matt Anderson could give us the 60-second highlights of what some of the limitations might be, I think that might be prudent.
I agree, it'd be great. Mr. Anderson, do you want to comment?
Thank you, Mr. Chair. Senator Benson, the main maintenance of effort requirements or the main restrictions that Congress enacted for states to be eligible to receive the enhanced FMAP is that states must agree to cover all COVID-19 related testing, treatment, and vaccinations for our Medicaid enrollees without any cost sharing obligations. States cannot increase our Medicaid premiums rates for population categories like employed adults with disabilities that pay a premium for Medicaid. We can't increase those premium rates beyond what they were set at on January 1st, 2020. States cannot make conditions of eligibility for Medicaid more restrictive than they were as of January 1st, 2020. And we have to keep all of those conditions, all three of those conditions in place through the end of the quarter in which the federal public health emergency ends. And then the fourth requirement, as Mr. Greenman mentioned, is that we have to maintain continuous coverage for enrollees who were enrolled on or after March 18th, 2020 through the end of the calendar month, not quarter, but month in which the federal public health emergency ends. That last condition is what's referred to as the continuous coverage policy.
Mr. Chair?
Mr. Albrecht.
I believe there's also one additional requirement that says we cannot increase the local government share.
Oh, okay. Senator Benson, did you want to?
Nothing further. We have a big agenda. Thank you, everyone.
So let me just ask one question and then we'll move on. So I'm just picking a random example that I don't know that I even want to touch, but just so there's criteria to get into a nursing home. Could we adjust that on an acuity basis and maintain our maintenance of effort? That's just a totally random question. I'm not suggesting we do, but if we would be allowed to do that under the maintenance of effort?
We cannot restrict, Mr. Chair, we could not restrict the benefits or coverage of what we would provide. So if we are making changes that would limit a person's coverage or benefits, decreasing what they would be eligible for, that would violate the maintenance of effort.
Okay, that was my question.
Okay, thank you.
That's good for now. This is very instructive. And if anybody is not muted, I don't see anybody popping up as making noise, but sometimes if you're not muted, you might find something embarrassing happening on the phone or something. But so if you're not muted, please do that. Mr. Greenman, go ahead.
Thank you, Mr. Chair. Just to wrap up that first adjustment that we talked about with the public health emergency, we project a reduction in spending of about $310 million in 2021. And that's the net impact, which is about 34% of the total reduction in the current biennium. We also project a cost related to as we unroll, I guess, or sort of return back to normal in terms of the medical assistance continuous coverage piece. We expect that to happen over time in fiscal year 22. And so there is actually a cost of $58 million in fiscal year 22 for while we roll back that the continuous coverage piece. The second main adjustment that occurred that's affecting the forecast is lower than expected utilization of services for both medical and non-medical services. What we saw in the spring was basically the restrictions that were placed on self-isolation restrictions put almost a complete stop to preventative and elective care utilization. And what that resulted in was lower average costs of fee-for-service claims, as fewer people went to the doctor, few people had preventive or elective services. We expect this to remain low through fiscal year 24 as well, as we expect it to return to pre-COVID levels in fiscal year 24 as well. And the other thing that we're seeing as a result of the reduced utilization is that managed care plans have in their contracts a minimum medical loss ratio that they can't spend less than a certain amount of their capitation payments on medical services. And it's expected that the state's going to take back some of those payments from calendar year 20 because they will not have met those minimum loss ratio requirements, or to bring them into compliance with the minimum loss ratio requirements. And we expect about half of, oh, sorry, go ahead.
Oh, that's fine. You can finish your sentence. Then Senator Nelson had a question a little bit ago. So
we expect about half of the rebate to be, or that we recover from the plans will be in June of 21, and the other will be in June of 22.
All right. That's so, Senator Nelson, if it's, go ahead and ask your question.
Yes, thank you, Mr. Chair. Well, it's just a comment. If we could have speakers share their screen so we can see the document that they are referring to, it would be incredibly helpful. We have about 20 attachments for this hearing. And so if speakers could identify the name of the document that they're referencing, and if they could share it on their screen, it would be incredibly helpful.
Yeah, I think you're driving us, so that's part of the challenge. We're on the nutshell.
Mr. Chair, just to be clear, I'm not driving. I'm a passenger in a car.
On the road. Sorry.
On the road, yes.
Very good point. Well taken. Brittany, is that possible, or is that realistic to do that at this time, to fill a document up there for people?
Yeah, I can do that.
Okay.
I know I'll just make a quick note when we get to Mr. Bunch's portion of this and later when MMB is going to present, they do have a presentation prepared, but I can pull up the administrative adjustment document that Mr. Greenman's referring to.
Okay, well, Mr. Greenman, keep going. People want to know more. They just want to even see it. That's how exciting this is. So it's
Right.
Or extravagant.
Okay. So the next, so basically that the lower utilization is resulting in general fund reduction of, Brittany, I think that's actually the wrong document. It's the nutshell document.
Oh, okay. My bad. I'll pull that one up.
So the lower utilization is expected to result in a general fund reduction of about $293 million in the current biennium and a reduction of about $190 million in the next biennium. And that's actually 74% of the reduction in the next biennium results from the lower utilization that we expect, the effects of that on expenditures. The third adjustment we wanted to talk about is a base adjustment we made due to actual enrollment during COVID-19. As I mentioned earlier, we have to maintain continuous coverage, and the commissioner adopted a number of executive order waivers to maintain continuous coverage. What we found was that we overestimated the actual enrollment that would occur, or the enrollment effect of those waivers. And so there's less enrollment than we had thought there would be. In other words, there are fewer people staying on the programs than we thought would result from that. We also projected that there would be a growth in enrollment due to the recession caused by COVID-19, and that turned out to be accurate. But we did find that the enrollment's lower than we expected back in May. And so what we're actually seeing is a projected general fund reduction of $203 million in the current biennium and a reduction of about $119 million in the next biennium.
That's very good. Mr. Greenman, Senator Marty has a question, but before he does, we're referencing a May forecast that everybody admits was, hurriedly done and full of assumptions. At some point, could it be possible to have a comparison with the February forecast on some of these so we can get a more real indication of what effect the COVID had? I don't think that's for today, but is that a hard document to put together? I don't imagine the whole thing, but how much can be done with relative ease about that?
I believe that we can work on something like that. I'm not sure how much work it would be for our reports and forecast unit, but we can certainly work on something like that. I mean, I think what we would have seen was smaller changes. To your point, Senator Abler, we would have seen smaller changes if we had just used the February forecast and not tried.
But then we could see what enrollment was compared to what we thought. So it bumped up. Now it looks like it's going down, but it's going down less than it was going way up. And anyway, so we'll talk about that maybe offline a bit. Senator Marty.
Thank you, Mr. Chair and Mr. Greenman. First of all, Senator Abler, I hope that they can share us the February forecast compared to this as well. But in terms of the reduced utilization due to COVID, I'm just curious, percentage-wise, the reduction that was for the fee-for-service segment and the percentage-wise expected from the managed care plans, and what percentage take back is that going to be from each of those for that item?
Mr. Greenman.
I can pull that up quickly for you. You're going to find the vast majority of the reduction is in the fee-for-service programs for a couple of reasons. One is we don't manage care plans essentially. The minimum loss ratio, and maybe Mr. Anderson can quote what it is. I don't know exactly what the minimum loss ratio is. I imagine it's maybe somewhere between 85 and 90%. But so plans don't have to give back dollar for dollar the reduction in utilization. That's one factor. The other factor is we're looking at an overall impact on utilization in the fee-for-service area that's going to go on for several years, we think. So there's two reasons why it's significantly more. Let's see. Do you want? I can, if it's helpful, I can just send you the information. But that's basically probably 85% of it is fee for service.
Senator Marty.
Mr. Chair, even though vast majority is in managed care, I just wonder, because just saying that they can keep everything up to the minimum loss ratio doesn't reflect the reality of what they're a lot better off if they do it that way than if they give us the share back that we should be getting back. In any case, because of the shortness of time, if you could send me that, I'd very much appreciate what percentages and how much you're expecting back from the health plans versus how much you're getting back in the fee for service as a percent of what you were spending on it. Thanks.
Certainly, we can do that.
Mr. Gaiman and Senator Marty, I just want to pile on a little bit there. If indeed, the percentages, and today is kind of overview day, and maybe you and I can work on something, but it seems there should indeed be a clawback from the health plans. Some of them, I won't mention any specific names of health plans that have been famous for clawing back monies that have been spent or expended in good faith, and they decided just to start taking back money from providers, and so I would think the ratio should be comparable, and I think that voluntarily or involuntarily, as we face a deficit, that they shouldn't get to keep that. So that's not in my jurisdiction, but it's a topic that I think is worthy. Mr. Greenman.
Okay, so I've gone through the three main adjustments that are affecting the forecast, and you're going to see those throughout the medical assistance, the individual details that I'm going to go through now. And I'll just go through the major items because I know you've got a lot on your agenda.
Well, Mr. Greenman, do you? I guess if you have a short overview there, and I think we could go to questions and have more specifics that people might have. But just kind of fly through that next part that you're going to do.
Sure. So what you're seeing under long-term care facilities, MA, the average cost for nursing facilities was lower than what we expected by about $46.1 million. As you may recall, there was an emergency order, the commissioner used her statutory authority under public health or peacetime emergency to allow nursing facilities to claim immediate reimbursement for COVID costs. And we assumed that a certain uptake by the nursing facilities to do that. We found that happened less, or to a lesser extent than we thought. And so expenditures have gone down for that. There's a couple of smaller adjustments. And then one thing I wanted to point out is the statutory FMAP increase. This is our permanent FMAP. So the 56 or the 6.2 percentage point increase during the public health emergency goes away, we assume, in June. And we go back to our regular FMAP rate, which for most populations is 50% state, 50% federal. It's been 50% for quite a while, and that's based on the Fed said it based on comparison between the state's per capita income and the national per capita income. And we've always been at the minimum, which is 50%. However, it's expected that in October of 2001, our FMAP rate will go up to 50.51%, which is a small increase, but it does result in $113.8 million in savings over the entire MA program in fiscal years 22 and 23. So that you'll see that throughout this document as well.
And Mr. Gaiman, Senator Bingham has a question about IMDs. This is a good time for that? Senator Bingham.
Thank you, Chair Abler. A priority of mine has been figuring out how we hold the counties and the tribes harmless from the billing issues that occurred last year regarding substance use disorder treatments and IMDs. I'm wondering, Mr. Greenman, how is DHS accounting for that? I believe they were clawing it back. So there was erroneous billing, and then the state was clawing back, and the feds were, for their portion, the state was clawing back, and it has been discussed about trying to hold them harmless. So I'm wondering, how is DHS accounting for that now, based on everything we're kind of seeing today?
Mm-hmm.
Mr. Greenman.
Mr. Chair, Senator Bigham, what we're assuming in the forecast is basically the state, we're essentially following what we have to do in statute regarding the take back of the payments that you're talking about, the IMD and the tribal MAT payments. And so we're assuming that they will be repaid to the state in the forecast, absent legislative action to do something other than that. That's what we're assuming.
So what you're saying
Senator
is that
Bigham.
we probably need to take, thank you, Mr. Chair. So what you're saying is we need to take legislative action to hold our local government partners and our tribal partners harmless for an erroneous billing.
Absent that, we would follow what's in statute and recover the payments.
All right. Thank you, Mr. Chair. Thank you, Mr. Greenman.
Yeah, Senator Bigham, I hope for a different outcome than that. I think that, Mr. Greenman, there's a lot of content here, and with this, this amazing document you've come up with, and people's ability to read, I think I don't want to go through every one of those items, because I don't think that it's going to be interesting for people. I mean, it'd be fascinating. I mean, especially for the wonkish ones in particular. But like you mentioned, the highlight, if there's some highlights that are important, like the 50.51%, that's a really meaningful thing to know.
Sure.
And you just glance over that and look at some trends, and then I'm going to open it up for questions about specifics. And I think a lot of the things that are going to be, then we can just focus on what people really want to know something more about.
Okay.
All right.
I'll just point out, take a couple minutes and point out a couple other issues. Under MA long-term care waivers, we're seeing about a 5% to 7% increase in the CADI, CAC, and BI average cost, which is having a cost impact on the state. What we're projecting, or we're not exactly sure the reason, it's mostly in the CADI program, and we think it may have to do with increased utilization of customized living. But that's one of the items I guess I would point out. Also under the waivers program, we are required to implement electronic visit verification starting in calendar year 21 for the PCA program. We had some unexpected delays in the implementation, and so we're going to actually have to face a penalty from the federal government for failure to implement. We're actually one of 40 states that's going to probably be facing a penalty unless the Congress acts to delay the penalty. But we're so you can see there, it's about a $3 million cost in the current biennium and $18 million in the next biennium.
And most of that wasn't penalty; it was probably just failure to save the money we were hoping to save. Is that right?
It's close to half and half. Yeah.
Is it? Wow. Okay.
Yep.
Thank you.
So under MA elderly and disabled basic care, you can see the impacts of the three items I mentioned earlier. The other thing to point out is we have a federal clawback that the feds do on us related to the Medicare Part D coverage for prescription drugs. They basically, when they passed Medicare Part D, they decided that they'd claw back from the states what they think the states would have paid under Medicaid if those seniors had gotten drugs through the medical assistance program. But because of the FMAP bump that we received temporarily, we're seeing a reduction of $36.3 million in the current biennium due to the reduced clawback payments. There's not a lot of changes that I haven't already discussed for adults without children. For the MA families with children basic care, we are seeing higher managed care rates in calendar year 21. We're looking at about a 5.2% increase versus our trend assumption, which was 3%. So we're seeing a higher cost in that area. We're also seeing savings due to pharmacy rebates, increased rebate revenue. We worked with the Office of Inspector General on the federal level to identify a universe of payments for pharmacy that we didn't claim rebates on, and we went back and claimed those rebates. So we realized a one-time windfall of about $74 million in the current biennium. Then I'll go on briefly to the CD treatment program, which is I think on the next page of the nutshell. Again, you're just seeing reduced utilization and the extension of the public health emergency. Under the Minnesota Family Investment Program, we saw an increase because of how we had to implement one of the executive order waivers that put people immediately onto the MFIP program rather than putting them through the diversionary work program first. And the result was that we put them on a state-funded program temporarily. We are trying to, we looked at recovering, putting them back on the regular MFIP program, which we're going to do early in January of 2021. However, we looked at doing sort of a retroactive adjustment, putting them on the regular MFIP program retroactively. With the closure of the federal fiscal year on September 30th, we're not able to go back before September 30th. We're looking at going back to October 1 and going forward to see if we can make a retroactive adjustment then. So we are looking into that. In childcare assistance, we're seeing reduced utilization due to COVID. There's a little change in the other programs, the North Star, General Assistance, Housing Support, and Minnesota Supplemental Aid. There's not a whole lot of changes there. The one other thing I would point out, the last item I think is under the Minnesota Care Healthcare Access Fund. We found out that recently in the Federal Register that the calculation of the subsidies for the basic health plan are going to include a premium adjustment factor, which is good news for the state because then we realize about $79 million in additional federal subsidies coming into the state, which results in a reduction in healthcare access fund spending in both this current biennium and the next biennium, because the premium adjustment factor affects both 21 and 22.
Okay, and Mr. Greenman, is that your, yeah, and Commissioner Malcolm has come, I guess. I'm so good at this, I only have about half the people on my screen. So we're gonna take a break away from this. We'll come back to questions about this. So Commissioner Malcolm, welcome to the committee, and Commissioner Harpstead, if we're gonna do about 15 minutes or so on the, my video went off again, I don't know why. Anyway, I'm still here. And so except for using the word, we're not going to talk about COVID. Welcome to a group where we're talking about something entirely different. And so the agreement I made with the Department of Health is we're not going to discuss anything about that other topic. And it's all about the blue ribbon and whatever else the commissioners want to talk about and on their time. So Commissioner Malcolm and Commissioner Harpstead, welcome to the committee.
Thank you very much. Welcome, Commissioner Malcolm. Chair Abler, Chair Benson, and committee members. I assume you can hear me? Good, thanks.
Yes, yeah. You can't see me, but you can hear me.
The Blue Ribbon Commission on Health and Human Services was created, as you know, by the Minnesota Legislature and Governor Walz at the end of the 2019 legislative session to develop an action plan, quote, to advise and assist the legislature and governor in transforming the health and human services system to build greater efficiency, savings, and better outcomes for Minnesotans. The commission, co-chaired by the commissioners of the Department of Health and the Department of Human Services, sought public and stakeholder input on ideas to consider as part of its work and culled through over 200 submissions to identify priority strategies to develop for inclusion in its final report. The commission organized its work by 5 aims defined in the legislative charge: health and human services cost savings, health equity, administrative efficiencies and simplification, waste, fraud, and program integrity, and system transformation. Given the emphasis within the legislation to identify $100 million to be saved within the next biennium, the commission focused its early discussions of strategies on ideas that would result in those savings without negatively impacting eligibility or access, and puts those strategies forward for the legislature's consideration today. In addition to strategies focused on cost savings, the commission also reviewed strategies included for the legislature's consideration focused on administrative simplification, reducing waste, and addressing health equity as directed by the commission's authorizing statutes. Of course, the COVID-19 pandemic disrupted everything and took the Department of Health staff out of the work, except for brief occasional consultations after March. We're pleased that before the COVID stay-at-home order, the commission had just finished collecting, organizing, pricing, discussing, and moving forward for consideration a list of cost-saving strategies that did indeed add up to $100 million. All commission members were disappointed that we had to set aside proposals for health transformation without our partners from the Department of Health, and that we didn't have enough time to complete the analysis and consideration of more strategies to address health equity, waste, or administrative simplification. The commission was also traumatized by the death of George Floyd and had to spend a couple of conversations healing from that and realizing how we had barely scratched the surface of the notion of true health equity. Our final report includes a call to action challenging Minnesotans to continue to pursue this conversation in earnest in the months and years ahead. But as I said, we are proud to have completed our final report on time in October with a list of strategies for consideration by the governor and the legislature that reflect our charge to find $100 million in savings. As you'll recall, if these strategies are not adopted into law, the plan was to move the remainder of the $100 million from the state budget reserve. Our list of cost-saving strategies include strategies to manage drug prices in Minnesota, to eliminate fraud in state-funded services, to allow for more effective managed care across providers, to allow for more effective utilization of disability services, to improve dental care access to low-income children, to make corrections to outdated provider rate structures, and in 2 cases, to eliminate no longer used or needed state appropriations. Some of the most popular strategies among commission members would create a uniform pharmacy benefit using the state's purchasing power to negotiate lower drug prices for participants in our public health care programs and create public commissions to examine ways to curb rising drug prices in the commercial market. A couple of strategies in the report call for additional fraud investigators in the DHS Office of Inspector General, positions that have a proven track record of uncovering fraud in human services at the rate of at least $2 in savings per dollar spent. A couple of strategies would allow for greater sharing of information across healthcare systems and providers to allow for greater managed care capability while protecting patient privacy. Another highly popular strategy among commission members was finding efficiency in the Min Choices assessment process for people with disabilities. Several strategies brought forward by the public and staff address more effective and equitable utilization of resources for services to people with disabilities, including case management redesign and a study to ensure equitable access to services. 2 strategies were identified to eliminate state appropriations for funding that's no longer used or needed. Every strategy put forward for consideration to commission members was put through a rigorous equity review tool developed in the DHS Healthcare Administration, and which DHS is now looking at putting in place as an ongoing standard across our department. Also, we did manage to run our final report by a wide range of 24 community organizations, such as Doctors for Health Equity, the Diverse Elders Coalition, Tribal Health Directors, This is Medicaid, the Minnesota Leadership Council on Aging, and the Consortium for Citizens with Disabilities. The entire report is available on the Commission's mn.gov website under Health and Human Services Blue Ribbon Commission. While the Commission is disappointed not to have completed its intended final round of vetting in order to recommend these strategies to you, we are proud to have collected, vetted, and discussed these strategies enough to commend them to you for your consideration in the 2021 legislative session. A mantra often repeated throughout the work of the Commission was that one person's cost savings is another person's revenue loss. So while some of these strategies may be unpopular with provider advocates, they may be less onerous than many of the other options you'll have to consider in balancing the biennium budget, and I encourage you to seriously consider them. So while COVID interrupted our original intention to tackle health transformation and health equity strategies, as fate would have it, we are able to present to you now 24 well thought out strategies for cost savings in the state budget in time for the 2021 session, where you'll be working to reduce the budget deficit caused by this pandemic. I'm going to turn it over, or ask you to turn it over to Commissioner Malcolm for additional comments.
Well, thank you. And I see Senator Kiffmeyer has a question, if that could wait to the end, unless it's pressing for this part. Okay. Welcome, Commissioner Malcolm. A whole new topic. You've been busy.
Thank you, Mr. Chairman. It's really nice to see you. Thank you, members. I want to just make a couple very brief comments. First and foremost, to thank my colleague, Commissioner Harpstead, and DHS staff as well for continuing the work of the Commission and really carrying the entire load after we became pretty consumed, to put it mildly, at the health department by that topic that we're not talking about. Other than the obvious, that COVID did indeed, as Commissioner Harpstead said, change the trajectory of the conversations. In another important way, though, I think that the impacts that the pandemic is having and will have in the long term on the continuum of health and human services is going to be really important. And I think in that sense, some additional time spent looking for those truly transformational opportunities that the Commission really was very enthused about. I was really struck in the early part of the Commission. Folks were very anxious to fulfill the statutory charge to come up with these shorter term savings, but there was such a strong sense across the group, to a person, that the size of not only the fiscal savings but the impact on better results for Minnesotans would be multiple times the short term savings if we really could get into those transformational strategies. And I do think that the impacts of COVID will influence those transformation conversations, and need to. I mean, we're going to need to transform more than ever, because the shakeout of the pandemic is going to affect the whole healthcare continuum. And it will take some time to assess that fully, of course, but as we know, some populations have been affected more than others, some providers more than others, and we're going to need to factor that in. I also think we are having some powerful learnings from this pandemic. Some truly heroic work has gone on, as I know you all know, among our healthcare providers, but among the public health sector as well. And I think we want to certainly celebrate that. We also want to note what the pandemic has shown us about where there are gaps in the system, how truly fragmented the continuum of services is, and I think you all, how fragmented it is, but how interdependent. I mean, I think this pandemic has really shown us that we just cannot think about acute care and long-term care in such completely different worlds because of the intersection of those and the degree to which capacity issues in one affects the other and the like. So I am again grateful to Commissioner Harpstead and our DHS colleagues for moving this work forward. It is urgent that we do continue, not only to take a look at those near-term opportunities to see which ones make the most sense given in the current climate, but also that we come back to some of those broader transformational opportunities. And I very much look forward to the day when we can have a robust conversation about the longer term and the bigger picture, and to even do so in person. So I look forward to that time.
Well, thank you very much. And I had a few questions about specific things, mostly in the DHS side. But Commissioner Malcolm, while you're here, I'm just sensitive to that you might have other things to do today besides enjoy our very interesting discussion about all the math. So, so perhaps if it's okay with you, we could have you entertain questions about the Department of Health elements. If we're not going to go through the list, people can read, and it's been around for quite a while. And in the attachments are lists of letters from various groups that have generally concerns about some of the things. Nobody said great idea, but they're thoughts to work through, as both commissioners have mentioned. If there's any questions for Commissioner Malcolm about any of the MDH components, this would be a good time. I see Senator Benson is unmuted. Oh, yeah, Senator Kiffmeyer, you were first, so and then Senator Benson.
Thank you, Mr. Chair. Commissioner Malcolm, my question for you, I appreciate the fact that we've learned a lot going through this, but as a nurse myself, the classic way of treating outbreaks like this is to quarantine the sick, to protect the vulnerable, shelter them, and the rest of us, we got to go doing our business to help maintain the structures that take care of both the vulnerable and the sick. So in this learning situation that you're referring to right now, since we've had these most unusual government shutdowns of businesses, churches, all manner of things, disrupting a great deal of our life and emotional, social well-being, the human beings that we are, do you foresee in the future that this is going to happen again, and that again, we will be going through successive times of this kind of a shutdown? Could you address what you think about that for the future?
Senator Kiffmeyer, and I have the highest regard for you, but this is not the venue for that question. I kind of made a deal with the commissioner that we weren't going to have that topic. I would be ahead of you in line with some of the same questions, but just to be polite to what I've committed to, unless the commissioner wants to comment, I don't think she has to answer that question, but
it's okay.
Ahead.
Yeah,
That's
Mr.
right.
Chair, no, I did not know about that such of a thing. I was just taking off of what Commissioner Malcolm said about lessons learned.
Oh, yeah.
So no, we can defer to another time, or she can discuss it with me privately if she wishes. Thank you.
Commissioner Malcolm, what's your pleasure? Do you want to just talk about the blue ribbon thing?
Well, yeah, I thank you, Mr. Chair and members. I appreciate that. I am more than welcome conversations about where we are with COVID and lessons learned at another time. So I think we should stick to the Blue Ribbon Commission this morning, but I'm very happy to come back and talk.
I'm sorry I wasn't more clear about that to members. So Senator Benson, did you, and then Benson, then Jensen, and then whoever else.
Yes, I just wanted a broad view as we start this conversation. Maybe Mr. Greenman is still on, but the 100 million that we're supposed to save is already calculated. This isn't addition. This isn't solving for the upcoming deficit. So if Mr. Greenman is still on, if not, I'm sure Mr. Albrecht could help the committee understand that the savings from the Blue Ribbon Commission are already in the budget. They'll be sort of off spreadsheet if they're not accomplished. So if our finance folks could give us some advice, I'd appreciate it.
Mr. Greenman.
Sure, Madam Chair. What in 2019, there was a provision, Senator Benson's correct. It's already booked as savings in fiscal year 22 and 23. The Blue Ribbon Commission legislation actually made an adjustment to assumed a reduction basically in Health and Human Services spending of $100 million in 22 and 23 and booked it, and essentially said that if the way the law reads is to the extent the legislature doesn't pass the Blue Ribbon Commission recommendations or identified policy changes equal to $100 million, the funds would be taken out of the budget reserve. And so that's sort of the backup in case these items aren't actually adopted. So yes, you're correct, Senator Benson, that they are accounted for.
Senator Benson, did you want to? Okay, Senator Jensen.
Thank you, Mr. Chair, and thank you, Commissioner Malcolm. I'm really not trying to do an end run around your restrictions, Senator Abler, but I guess the question I have is the Blue Ribbon has worked so hard to try to reduce costs and things like that. But one of the questions I've had in terms of just Minnesota and the Department of Health, you've been strong stewards of the dollars you get. You're using the Blue Ribbon Council to, if you will, maximize what can be done for Minnesotans. But I did notice that in the CARES Act, there were 395 hospitals that received the high impact distribution dollars, which in many situations was up to $25 million if they hit a certain threshold of COVID-19 admissions to the hospital. And if we in Minnesota were able to make certain that we had our fair share of that, I would think some of the pressure for the Blue Ribbon Commission to find places to cut might be alleviated. So my question, Commissioner Malcolm, is of those 395 hospitals in the country that received the $77,000 per COVID-19 admission, do you know how many of those were in Minnesota? And do you think that we are getting our fair share?
Senator Jensen, I hate to be in this. My camera is working again, so the 14-year-old must have come by to fix it. I just hate having to ask you not to ask those questions here. We could have a special hearing, maybe in Senator Benson's committee. There's clearly a pent-up demand to talk about this, and I know the commissioner is very willing to do that. But I kind of made a promise to her and to her staff we'd talk about Blue Ribbon stuff, and knowing that
Mr. Chairman,
I have some of the same questions. So Commissioner Malcolm, as you wish. I just want to respect.
Actually, Mr. Chair,
Senator
could,
Benson,
Commissioner, I would prefer that those things that were primarily health and not Blue Ribbon Commission be addressed with the members of the Health Committee. We do not have much time today, and the Blue Ribbon Commission
How about that?
covers both jurisdictions. So I'd prefer we stick with Blue Ribbon Commission as was our agenda.
Yeah, so I hope that's okay, Senator Jensen. Commissioner, go ahead if you want.
No, I just was going to say on Senator Jensen's specific fiscal question about CARES Act dollars in Minnesota, I don't have that off the top of my head, but I think that's a relevant question we can get back to you on.
Yeah,
Thank you very much.
And it doesn't minimize the value of these questions. So does anybody have a question about the Department of Health collage of recommendations from the Blue Ribbon Commission?
Mr. Chair.
All right, Carla, thank you, please.
Thank you so much. Yes, and thank you, Commissioner. I know that you're extremely busy right now. I just had one question on the Blue Ribbon Commission. One, the ideas sounded very intriguing, and I like that fact of getting better outcomes with less cost in some cases. So, but my question had to do with the 100 million, and I understand how that will come out of the reserves if we don't find that. My question is, I thought I heard you say that the commission did not recommend those suggestions. And just to help get some sort of a view, do we know what the cost savings are in total that was recommended? In other words, how much savings was projected by all of those recommendations, knowing that we'll need to choose which ones might get near to 100 million. Do you have some feel for that?
Sure.
Commissioner.
Let me just say that all of the recommendations put forward in the final report do add up to the $100 million in savings. So, so the $100 million goal was hit by all the things in the report. What changed over time was the commission had forwarded several proposals to for future consideration, and had planned to go through one more round of vetting and prioritizing the proposals before the end of the commission's work, and we didn't get a chance to do that final round. And so these proposals have been submitted, vetted, priced, discussed, and moved on for further consideration, but we didn't have a chance to do the final recommendation. So it's really the word that's changed, not the dollar amount. It did reach $100 million across all these proposals, but the commission prefers to say that they're commending them to you for your consideration than to say they're recommending them.
All right.
Thank you, Mr. Chair.
On the queue, who's that? Who just talked?
Oh, I just thanked you. I thank you for the answer to my question. Yes, in other words, we'd have to adopt all of the proposals in order to reach the 100 million. And then I guess just the final thing is, why wasn't the commission able to take that last step?
Commissioner Malcolm, I want you to talk about the blue ribbon thing. This is your chance.
Well, I think, again, back to Commissioner Harpstead, I think it was just the amount of time that commission members spent on, as she said, vetting the ideas to a certain point. And they were very robust discussions in terms of folks understanding the implications, the potential unintended consequences. There was lots of discussion about if this were to be enacted, we'd have to pay special attention to a number of different factors. So I think, as Commissioner Harpstead said, the intent was to have a second round of discussions about each proposal with some of the further analysis that commission members had requested, and with some of those caveats, if you will, further discussed. And it was that last part that there just wasn't time with the adjusted commission schedules to do. So I think Commissioner Harpstead characterized it accurately, that these were all proposals that met the charge of the commission, but that did not come with endorsement per se, because all of the details hadn't been fully fleshed out by the time the commission needed to wrap up. But I would invite Commissioner Harpstead to restate anything I was too general with there.
So basically, thematically, the two departments agree with the details are to be worked out. Is that fair to say? So if there's a thing listed, that means you kind of like the idea as good concept.
What we were doing was saying, would these ideas, if enacted, achieve the goals that the statute laid out? The place where the discussion wasn't as complete as the commission would have liked, as Commissioner Harpstead said, was on some of the potentially on unintended consequences, particularly through an equity lens, that there was some thought that deeper analysis would need to be done on some of those.
Yeah, well, very good. And so part of why we're doing this lightly today is they're conceptual, as I pick up from you all. And if you like them well enough, they'll wind up in one of your budgets, and then we'll dissect them and see if we agree with the direction they're going in, because there'll be content and you'll have a chance to go through your equity lens and look at you'll have a number assigned to everything. So I appreciate that. So I've got Hoffman, Benson, and Kiffmeyer. So Senator Hoffman.
Thank you, Mr. Chair. And this is a good discussion. And I guess one of the questions I have is the blue ribbon panel that is putting together, my assumption is you'll have to do state plan amendments or proposed change or methodologies or restructuring something within that. are you looking at the blue panel as an obligation that clicks that checkbox that's saying this is the provider and public input process that we're supposed to do related to anything regarding access to care and public input processing?
Whichever one of you wants to volunteer for that. Neither.
I think,
Commissioner Malcolm. Yeah.
well, if the question was about a state plan amendment, I'd refer that back to Commissioner Harpstead.
Okay, Commissioner Harpstead then.
I think the proposals in the Blue Ribbon Commission have had enough background information put together and enough strategy and thought process to be what we would think of as sound strategies going forward. If they make it into bills during the legislature, we can certainly do additional technical assistance to answer any questions about that. And I can't say off the top of my head if any of them would require a change to our state plan amendment with CMS.
I see Mr. Anderson is unmuted. Did you have a thought, or did you just bump the button?
Thank you, Chairman. I was just going to say that for purposes of Senator Hoffman's question, any changes to our state plan amendment or existing waivers with CMS would require a separate public notice and comment period before being submitted to CMS.
That answers my, Mr. Chair, thank you. That answers my question, because there is a public input process that is assigned both in the Social Security Act and with Centers for Medicaid Services. So that's the question I was seeking. And so thank you. I appreciate that.
All right. And then I have Benson and Kiffmeyer, but I just to clarify, and then Michelle can pop in on this too. So if the 100 million is already booked in the forecast is coming out of the surplus, out of the whatever the budget reserve, then it actually is going to be an on-budget discussion, and then but that won't go to the general fund. It'll backfill the reserve probably. All right, Senator Benson.
Thank you, Mr. Chair, and I'm going to ask probably Mr. Bunch, Mr. Greenman, could you go through and send to Mr. Albrecht any of these provisions that would be impacted by the restrictions on enhanced FMAP, just so that we have a better idea of what we can actually enact while the feds are under a health emergency jurisdiction. I am reading them and I don't know exactly which ones would be impacted by enhanced FMAP, but could you get a document to Mr. Albrecht if there are any restrictions on any of them that would impact the enhanced FMAP? I would appreciate that.
Did you unmute? Did you want to just say yes or something? Go ahead.
Mr. Chair, Madam Chair, just one clarification. This would be proposals that could be impacted by the MOE requirements for enhanced FMAP if it were to be extended past the June 30, 2021 assumption in the forecast. Is that correct?
Senator Benson.
If any of these provisions in the budget we're about to plan would impact an enhanced FMAP, because the feds might extend this and MMB might choose to extend, and we need to have some visibility on if any of these would impact the enhanced FMAP. And we can take this offline if you need further clarification, but I want all of the finance members to understand we're working in a really dynamic and restrictive environment. And so not everything is going to, the world doesn't look the way it was when we passed the Blue Ribbon Commission.
Understood, Mr. Chair. Thank you.
And I saw Lisa, I don't even pronounce your last name, I'm sorry, but did you unmute on purpose to comment about this or not?
Oh, no, I'm sorry.
Okay, that's fine. I'm just trying to be responsive to staff because these are really very important questions. Okay, so Senator Benson, you've asked her, are you done? Senator Kiffmeyer.
Thank you, Mr. Chair. In regards to the Blue Ribbon Commission, so I read the report actually when it first came out. And so I understand that it's not all complete. You didn't get to do that final step of reviewing things, but I don't know about that. All I know is what I was able to read. In several of those 24 situations, there was a range of savings from 1 million to 10 million. So my question is, what is counted towards the 100 million? Is it the 1 or the 10, or is that still yet a final step? And the last thing, Mr. Chair, is if money is going to come out of the reserve, how do we count it as savings? So I'm just a little bit puzzled by that whole arrangement. The main thing is what is counted when there's a range of savings.
And Senator Kiffmeyer, I think it was a contingent savings that backed by the reserve. And so the money is already in the forecast from the reserve just to cover the contingency. And I don't know how it's going to be accounted for, but somebody can say that. And so whoever wanted to respond to Senator Kiffmeyer's question.
Dave Greenman to answer the question about the ranges and some of the proposals in the Blue Ribbon Commission and perhaps the accounting for the reserve.
I was wondering how that added up to 100 when you have 1 to 10. So that's a really good question. Mr. Greenman, answer the hard question, please.
Mr. Chair, Senator Kiffmeyer, the ranges represent, because the Blue Ribbon Commission looked at a lot of these proposals sort of conceptually, we didn't have, as people say, the devil is in the details, and the actual fiscal impact would be, could go from 1 to 10, or, you know, the different ranges we provided. We were trying to provide sort of the order of magnitude of the various proposals that were put forward. We did do some analysis of, you know, how much it would save if we implemented it a specific way, and that to Commissioner Harpstead's point, that's how we got to the 100 million. But there's different ways of implementing some of these proposals, and so that's why we had a range in there. And happy to provide more information if that would be helpful.
Yeah, Senator Kiffmeyer.
Yes, Mr. Chair, I think there's a lot of more information, and I understand the circumstances that what you were planning to do was interrupted. You weren't able to finish it all the way, but it still needs to be finished, because as we come into the next session, dealing with ranges when you're doing fiscal notes and your accounting, and also in some of those that I read, it would actually take some changes, possibly in statute or possibly some other things. I couldn't quite tell for sure. I think Mr. Greenman was kind of referencing that. Depends upon how it was implemented. So I saw some costs that were in there as well. And I couldn't tell for sure if those costs to implement were accounted for in the savings. That's kind of where I'm going on this. But as a finance committee, we're going to have to be a little more specific when it comes time to consider some of those. And I wanted to bring up the questions now, so maybe they could be addressed in the meantime. Thank you.
Senator Kiffmeyer, your point is well made, and we're just close to bringing this in for a landing. I do want to remind folks that if any of the recommendations go forward, they would be part of the budget or some side thing coming out of the departments. And I presume they'll be fleshed out with bona fide fiscal notes. And I do hope that if things like the pharmacy purchasing and the dental purchasing are brought forward, that they're brought forward as standalone items, not as a conglomerate like it was before, so we can really see the effects of them all. And it should be no surprise that some of the topics in our arena I find to be a really poor policy, and we'll discuss those if they even come out of it. Either commissioner want to offer any more thought about this while we bring this
Actually,
segment to Commissioner
Mr. Chair,
yeah.
if I could, I just want to echo bundling these all into one governor's proposal as Blue Ribbon Commission and putting $100 million savings on it is not going to help us effectively make decisions. So each provision should be standalone and accounted for as we would with a fiscal note. So thank you.
Again, you and I agree.
For raising
Amazing.
that. Again,
yeah.
Twice in one day.
So many times. Anyway, so Commissioner Harpstead, did you want to offer a closing thought? And I'll let Commissioner Malcolm say goodbye in her own way, and then we'll wrap.
Sure. Just a couple things. We could certainly do a spreadsheet showing you how we got to the 100 million and what we assigned to each of the proposals, so that's no question about the ranges that you see in the report. The other one thing I wanted to mention is that we vetted all these proposals that came in from all over Minnesota and looked at enough of them to meet the charge of the commission to add up to 100 million before the February forecast, the May forecast, and the November forecast. And so the 100 million was a benchmark to be sure that we had looked at enough proposals to meet the charge of the commission at the time. But certainly each one of these will need a fresh fiscal note.
Perfect. So, Senator, thank you very much. Commissioner Malcolm, thanks for taking the time. Do you want to say something in closing?
Thank you. No, it's just very nice to see you all. And again, my appreciation to Commissioner Harpstead and Senator Benson. Just appreciate also your acknowledgement that the world is different than when we first, when the legislature and the governor's office kind of conceived of and gave the charge to the commission. So it will be a good discussion as we get into the session. Thank you.
Thank you, Commissioner. I'm glad we could keep the focus here, but I do hope you recognize there's a lot of interest in topics other than this, and the more private discussions that can happen about that. I know you're very busy, but some of these are just very important to us. So I'm grateful for your work and for your department. I think I kept my promise.
Thank you, Mr. Chair.
So with that, thank you very much. And so we'll revert now to the questions about the budget forecast. With Mr. Greenman, I don't have anybody with a question yet, but this is a good time for questions about the global forecast that we were talking about in human services world. Is there questions about that? Senator Hoffman, you must have a question. You're sitting there with a question on the tip of your tongue.
No, I was wondering and I sent an email just to let folks know. I mean, and I see MMB is on this call as well, Jim. I guess this would be a good time to ask that question because it is a fiscal dollar amount with the Jensen settlement agreement now 10 years later being done. The judge is sending $600,000 back. That money was for people with disabilities and people that were part of that settlement agreement within the Department of Human Services. And I would wonder, and I do want us to take action so that money goes back to the Department of Human Services and not to the general fund of the MMB, because that should be something that I think should stay within the jurisdiction of human services reform, and that money is deeply needed based on this projection that we're looking at. There's going to be some serious cuts here and lots of amendments being done on the state plan, lots of public discussion. But I guess that's a question to you, Mr. Chair, more than anything else. Thoughts?
And thanks. And I do hope that can be retained and used for some worthy purpose, somewhat parallel to the protecting the people that were vulnerable with the Jensen thing. And I don't believe the commissioner is prepared to answer that, but if at least she takes note that we're concerned about that. And the commissioner, who would we talk to on your staff about that to flesh out a proposal?
Well, I can take it back, and most of the staff you need to talk to are listening to now.
Okay. All right. So Senator Hoffman, I think you made your point. So let's move, thank you. If there's no questions specifically to the forecast, let's move on to the Healthcare Access Fund with Mr. Bunch, which I was shocked to see the trajectory of that. So Mr. Bunch, do you want to take it away?
You bet. And I also, Mr. Chair, Madam Chair, Travis Bunch, Executive Budget Officer on MMB. I did prepare a couple of slides that it looks like Ms. Lane is putting together. While that's getting brought up here, there is in that lengthy packet that you received a hyperlink to the full Healthcare Access Fund statement, which is 3 pages long. It includes the accounting for the Access Fund plus 2 pages of narrative. So I'm going to be pretty high level and brief with this presentation, go quick, but if you want more information, that is a good resource to review as well.
This is a good place for a high level discussion. So thank you. Go ahead, Mr.
You bet. And so just as kind of context and a reminder, when we ended the session back in October, the forecast for the Healthcare Access Fund anticipated a $141 million deficit in 22 and 23. And this table here lays out how then the changes with this forecast brings the expected balance in the next biennium to $170 million positive balance. And you recall in Mr. Greenman's comments right before we switched over to the Blue Ribbon Commission conversation, he was talking about the new assumption with the premium adjustment factor and the state expecting to receive additional federal funding for the basic healthcare program to the tune of about $140 million, which lowers state expenditures. And that $140 million is across both 21 and 23. And so that lower expenditures you'll see is reflected here in this table, plus other expenditures that were reduced in the forecast. But that coupled with revenue collections, which we haven't yet talked about, most of the provider tax revenue that comes to the Healthcare Access Fund is from the provider tax, but there are other revenue sources to the fund. There's an HMO tax, there's investment earnings, there's financial participation for administrative costs. But for the most part, the provider tax is the major driver of revenue for the fund. And in this forecast, we are now anticipating a $72 million expected increase in revenues compared to our end of session forecast. Most of that is driven by the provider tax. And that is largely due to higher than expected collections in the first quarter of fiscal year 21, plus a slightly stronger growth rate in revenues into the out years. And that increase in base and trend kind of carries on into 22 and 23. So just to step through this quickly, we started our current biennium at $373 million. We increased our revenue collections by $72 million. We lowered our state expenditures by $105 million, and we get to a positive forecast balance of $552 million. That's a $180 million change for our current biennium. Looking at then 22-23, we started with a $141 million deficit, but we increased our balance forward by 180. We increased our revenue collections by 184 million. We lowered those state expenditures. And then something that I really wanted to touch on, the 16A transfers. The Healthcare Access Fund, based on 16A statute, is required if resources are available to make a $122 million a year transfer back to the general fund. Back at the end of session in our forecast, it was actually back in our May budget projection, when we anticipated that deficit, we reduced those transfers because resources weren't available to make the transfer. But with this new forecast and with the changes in our revenues and expenditures, and now that we have a positive balance in our 22-23, we can restore those transfers. And so that adds another 127 million to our general fund, but it takes 127 million out of the Healthcare Access Fund. And with all that great math, Mr. Chair, that's how you get to a $170 million balance in this current biennium for the fund.
And Mr. Bunch, the restored 16A transfers, is there a reason those weren't called out in the HHS portion of the most recent forecast?
So I guess, Madam Chair, or Mr. Chair, Madam Chair, what you're suggesting is that it wasn't called out necessarily in the narrative. It is a line item in our fund balance accounting that was published.
Okay, I just
and
didn't
it is
see
also
it.
called out in
Thank
the
you.
access fund. Yep.
Thank you.
You bet.
And so is that your last slide for now?
There's just one more slide because we get to look at
Just keep going.
20. So this slide, we get to see now what 24-25 biennium looks like. It will be our first view. So we just talked about the 22-23 biennium. But when you look at 24-25, we start with a beginning balance of 170 million. Our forecast revenues are expected to be 1.9 billion. That's a $137 million biannual growth from 22-23. Our projected spending is expected to be about 2 billion, but that leaves us with an ending balance of just short of 15 million. That is after, again, because we have an expected deficit in 24 and 25. That is after reducing those 16A transfers by 122 million. That is also why you see in the biannual growth number of -60, why you see that it looks like spending is being reduced over the biennium. It's because that spending number includes both expenditures out of the fund as well, or expenditures out of the fund plus the transfers out of the fund. So when we reduce that $122 million transfer out of the fund, it kind of skews that biannual growth.
I appreciate that. And actually this other form that's not listed with the big table is one of my favorite. I don't know why, it's just my personal, I really like always looking at it, and you can see where the money goes. And it's not in the jurisdiction of my half of the committee, but it's something that has to be on our mind. And the novel number in 24 is that gets down to 0. It's seldom do you actually get to just a genuine 0. So that's calculated based upon taking less money out. But that also means that the general fund will be having a deficit of $125 million or so in the 24-25 budget, which is to be addressed on top of everything else.
That's Mr. Chair and Madam Chair, that also is lined out in our fund balance for the general fund. So you would see, that reduction as well.
All right, I appreciate that. And I'm not saying you're being clever. It's just not good news.
I'm not clever, Mr. Chair.
And so any questions about the Healthcare Access Fund?
Yes, Mr. Chair.
Oh, Senator Nelson, yeah, sorry. Yeah, you're on the list.
Yes. Would you like me to wait my turn?
No, now's a good time. We're done with the presentation.
Thank you. Mr. Bunch, thank you for the presentation. I have one overall question that maybe this isn't the time, or perhaps if you know, what % of the Healthcare Access Fund dollars are now being used to actually provide healthcare access? It's kind of a broader question, but I think it's one that should be addressed. And then secondly, I know I brought it up in finance. I think 2 people brought it up here today as well. It's this idea of comparing this unusual May forecast and rather than comparing our traditional February forecast to the November forecast. And I'd like to know the numbers that you're showing us today, are these numbers changes from that unusual, the worst of the valley May forecast, or are these changes or look ahead based from the February forecast looking to the November forecast that we just saw, a couple weeks ago?
Mr. Bunch.
Sure, Mr. Chair, Senator, to your first question, we'll have to get back to you on the percentage of spending out of the access fund that is for healthcare access, particularly thinking about what the definition of that is.
Yes.
To your second question, these numbers are based on the end of session forecast as of October. So it would incorporate the May adjustments plus any changes to healthcare spending or the Healthcare Access Fund spending that occurred in any of the special sessions that happened as well as any program modifications under the executive order that were implemented during that time. And so it does not go back and look at a change from February forecast. However, in our Healthcare Access Fund statement, if you look on page 2 of it, at least for the revenues, we have a chart that shows what the February forecast revenues were projected at for the provider tax, and then what our significant adjustment down was for the May interim budget projection, and then where we then landed with this forecast for November. So you can kind of see that, change in what And potentially that can help, at least for the provider tax revenue.
And Mr. Bunch, would it be safe to say that the one page, this table, if you can see, it's kind of funny. This is actually reflective of actual and the things as it stands today with what you thought you were ever getting. And so there's no oddling variability. This is just what it is, this summary statement, right?
So that summary statement shows what the actuals were for fiscal year 20 because we closed it, plus then what we expect it to be based on our November forecast. So,
all right, great.
Yep.
Senator Nelson, did that cover what you needed?
Yes, Mr. Chair, Mr. Bunch, thank you. I'll definitely look at those actual numbers. That will be incredibly helpful. And no, that was most of the genesis of my question. And I'll look forward to hearing, though, how much of the Healthcare Access Fund is actually paying for healthcare. And this may be pertinent to Mr. Bunch, but it may be for a different presenter yet to come. But if I understood our previous testimonies, that the state of Minnesota received increased revenue because of the increased FMAP match, but we had lower utilization of medical services. And maybe I can get some further detail on that later, but it seems like that actually is, if there truly were a budget surplus, that it truly would have been from those increased FMAP payments and decreased medical services. And is that an accurate analysis of what we've heard?
Mr. Bunch.
So, Mr. Chair, Senator, I think what you're saying is that we had increased federal share for medical assistance program, plus we had some lower utilization. And so we have, those two things are part of the big reasons why we have a $919 million reduction in our spending, or our anticipated spending in the Health and Human Services area. And I think what you're suggesting is that lower spending aids, I guess, so to speak, in what our ending balance is for our general fund for the enterprise. And that there was a significant, that had a significant impact along with all the other changes in our forecast. Is that, am I suggesting that correctly?
Senator Nelson, is that helpful?
Yes, Mr. Chair, Mr. Bunch. Yes, that is kind of the genesis of my question, except that also during that same time, we received increased payment from the feds for services. And so my question is, yes, if that's accurate, then the greatest concern is that we know that medical care that is delayed is often more expensive. And so it's just quite a concern to think that because of delayed or postponed medical care, we now have this, I hate to call it a surplus. I don't think that's the accurate term. But it's something that we must keep in mind here. It's very worrisome because that medical care that was delayed is still needed. And in fact, it could very well be quite more expensive.
Yeah, good point, Senator Nelson. So I just have one last question, then we'll move on to the next topic here. And I think we're going to actually jump to the fifth topic, the retention grants, just while the commissioner is still here. That should be brief, but I just have a few questions and I want her to hear those. Mr. Bunch, can you tell me why in 2023 that Medicaid medical assistance costs are frozen at that point? They only go up $1 million or something and then they're frozen. Mm-hmm. Is that a function of there's not enough money, or do you think that those costs are going to level out?
No, Mr. Chair, that is a function of somewhat of a budget rule. And so the allocation from the Healthcare Access Fund to medical assistance is set in our appropriations article. And so for fiscal year 23, the legislature and the governor enacted the appropriations article that set it at the $612 million that you see in the statement. As kind of a budget rule, we then push out that same level of funding into 24-25 because we don't have unless there was a a change with a planning estimate or something like that, that is the function of how we budget to 24-25. Does that make sense, Mr. Chair?
Right, and so it actually would create ostensibly a potential larger deficit coming forward on all kinds of levels. So, and I appreciate the rules. It's always something to learn about this place. So I think with that, I want to thank the discussion for these two things. I had a few questions about the retention grants I wanted to cover. I don't intend to go very deeply into those, but I wanted to get those while the commissioners still at least able to tune in. I'm told that some of the budget MMB people may have to leave by noon. I'm not sure if that's true from Ms. Raitan or not, but let's just jump to and then if you do, then let me know and we'll just switch the order around to accommodate that. We're doing pretty well. We're covering a lot of content, very meaty. And anyway, so Mr. Annett, are you there? And I'll just show my hand going into this. I read the report. It's very interesting. It seems that some of the one group in particular has never been heard of. Achieve sent in their thing on November 2nd. In the last couple of days, they got a note back saying, "Who are you guys again?" And I thought that was pretty amazing. I noticed that the numbers of awards were much lower than I would have expected. And so if you can comment about, I mean, Achieve's been around 50 years, so I think you've heard of them, and you gave them some money on the other part. So, and they have yet to hear after some inquiries. And so that's part of what provoked me to talk about this, but then thinking there may be some other entities that were left out or something, especially as I saw the total. So if you can fly through your presentation and then address that, and I would appreciate that. Welcome to the committee.
Sure.
There you are.
Sure, thank you. Thank you, Mr. Chair, Madam Chair, members of the committee. I'm Doug Annett, the Deputy Assistant Commissioner of the Community Supports Administration of the Department of Human Services. In October of 2020, the Department of Human Services implemented public health grants using $10 million appropriated by the state legislature, specifically to help day service and employment service providers adapt their service models to better support adults with disabilities, many of whom are at a greater risk of health complications due to the coronavirus when compared to the rest of the population at large. An additional $4.9 million was included in the public health grant pool from money remaining from an earlier retention grant designed to assist day providers through COVID-related closures. The retention grants provided financial relief totaling over $15 million to 209 providers from across the state who had experienced unexpected program closures due to the state shutdown this spring, while the public health grants focused on helping providers redesign their services so that they could be offered in a safer manner. Prior to the pandemic, many day service providers offered services in various size groups in classrooms and work floor settings that were not well suited for social distancing or effective infection control. This grant helped providers modify their services to provide a greater degree of individualized supports that were not as dependent upon those center-based models. In addition to expanding the use of individualized community-based supports, providers also deployed technology to support people through remote services, and those continuing to offer center-based services began to create smaller cohorts of participants receiving services, utilizing staggered shifts, and utilizing socially distanced spaces to minimize physical proximity. And they also had to dramatically increase their supplies of protective equipment and disinfectants. All of these adaptations required significant investment of resources for all of those agencies, and the public health grants really helped fund those efforts. Some of those investments that people have used have included things like hiring new employees to support increased individualized community-based employment services, supporting direct support staff through additional sick leave, overtime, hardship funds, hazard pay, investing in technology to support the remote services, and then also purchasing vans and office space to accommodate social distancing requirements. Some of the highlights we'd really like to call your attention to are MRCI. They're a provider in southern Minnesota that's used funds to permanently transition all of their DT&H and employment programs to community-based programs. LifeWorks, they provide services in the Metro, Hastings, and Mankato. They've transitioned from providing congregate day services and facilities to delivering individual supports virtually and in the community, providing skill building, music therapy, technology labs, and employment supports as well. Another, Opportunity Services, they sought funding to transform their business model for all employment and day services in Anoka, Washington, Scott, Carver, Goodhue, Dodge, and Stearns counties. They're transitioning their work crews into competitive employment. They're creating job opportunities through exploration, on-the-job training, work skills acquisitions, and earning above minimum wage in the community. And the last one I want to point out is Duluth-based UDAC. They are using their grant to permanently close their 14C sub-minimum wage program, transitioning their DT&H from a 6-hour in-building congregate program to a community-based individualized day in employment service. In total, with 84 providers from around the state were able to access up to $200,000 from the public health grants to fund their efforts to provide not only a safer level of service, but to add a greater level of inclusivity in this very unique time that we're living in, helping Minnesotans with disabilities remain connected to their jobs, their communities, and the important relationships that they value. These grants went to providers representing 50 different counties, with about 20% of the grantees providing services in the metro, while about 71% went to greater Minnesota providers. Obviously, COVID has been a burden on all of us. We've all had to adjust our lives, put our plans on hold, and be separated from those we love and care about. For people with disabilities, it's no different. And in fact, for thousands of Minnesotans who need a little extra help to find and maintain employment, access the community, and connect with those they care about, it's been even more difficult, especially when those organizations that they rely upon were not able to provide those services early on in the pandemic. But this funding has helped immensely. Well-being is not just a state of physical health or absence of disease. It's also the mental and emotional fulfillment one gets from being part of a community, socially connected, gainfully employed, and actively engaged in life, whether in person or in a virtual forum like we are now. And the work that was put into this grant is really work that's been put to fulfill people, and it's something to be really proud of. And so we really thank you for making these grants happen. I do realize there was a couple of providers who missed out on the grant. It was put together very quickly and utilizing a methodology that we wouldn't normally utilize for reviewing and delivering grants under normal circumstances, but we were required to create a process that fast-tracked these grants. And part of that was ensuring that people had a correct federal employment tax identification, looking through their billing history to make sure that they were properly enrolled for services and were able to deliver those services. And every provider that we were able to review, who we were able to verify all of those particular aspects by the deadline, was able to receive a grant. We do understand there was a couple who they may have incorrectly filled out some of their paperwork in a manner that when we went back to look at the tax identification numbers, the billing history, nothing came up. They did not show up as being eligible for those particular grant funds. And so there may have been a couple of cases in which people did not receive funds. And we are trying to reach out to those providers to find out a little bit more about what happened.
Yeah, and so I wish the time was more, but this was a way to keep these places open. And on the first part, I'm really happy to hear about some of the improvements and, the moving along on the other. But on any provider who got the first check, if there's some tiny error on their form, I hold the department responsible for helping them through this time. This is meant to be helpful, not a way to play got you and, oh, you missed a number or it was smudged or something. In the case of Achieve, they're still waiting for a reply. And like, who are you again? And I just don't understand that. And so I'm going to leave it at that. We'll take it offline. But this was intended to help everybody who could possibly help. And I think come January, when there's more time, we'll scrutinize how many of these places have just disappeared that are, I think we've lost more than 25% of them. And that's off this track here. But I guess I'm just because we're so short of time, I'll let you reply to that, Mr. Annett, and you're going to say, of course, we'll look into that and do all we can do. But there's no point to punish somebody for a typo, especially given these, they're all long-standing. There's no new ones of these. So you want to comment, and then I think we'll wrap it at that. So go ahead.
Yeah, I think staff was very pressured to meet the deadlines. We've had a very hard deadline in which we had to meet, and I know our staff really did our best to try to vet every provider that came through, looking through all of the materials that we had to ensure that we were properly paying out the funds so that we didn't inadvertently give funds to people who were ineligible for them. So again, if there was things that didn't match up within our vetting process, as far as providers didn't show up as actually being eligible within our systems, then those awards were not given, and there may have been some issues with that if the systems weren't connecting, and if there was information that we were not able to accurately vet. I would say that under normal circumstances, our normal grant vetting process would have been able to find these a lot easier with a little longer timeline. But in the short timeline that we had, we may have missed one or two.
Yeah, and I'm not okay with missing one or two. So maybe Mr. Burdick can set up a meeting with a few of us, and we can see where we need to go with this. So I'm going to have to just pull the plug on this now. But thank you very much, and I appreciate the work you did do. Hope you get that. So we're going to skip over Mr. Anderson just because some people have to go, and I knew we were crushing this all in. So let's take up number 4, the review of the fund, and perhaps if somebody can just give like a 1-minute overview, and then just to use the staff to the best ability. Members may have questions about a specific area that I would like to at least just deal with what people want to know. It would all be fascinating. So I don't think you have time to go through your whole thing. So Mr.
Certainly.
If you want to just say hello and say, look at all that stuff, who wants questions? But you can do better than that. But do like a 1-minute summary, and I'll open it up to members.
I can do that. Mr. Chair and Madam Chair, thank you for having me. My name is Britta Rayton, State Budget Director at MMB. We were asked to just give a high-level overview of the COVID-19 Minnesota Fund. This is the fund that was seeded with $200 million of general fund money back in March, and has a process of approval through the LCRC process, as well as the Federal Coronavirus Relief Fund, commonly referred to as the CRF. And so the slide that's in front of you right now shows the total authorizations from those funds to date, as well as remaining balances in those funds. I believe the committee members also received either last night or this morning the full detailed fund statements, which show all of the authorizations to date, as well as the amount of spending that's actually incurred to date, as well as encumbrances, and then the remaining unencumbered and unspent amount in each of the obligations from those funds. I have with me today and slides that I'm hoping you have received in advance, some details about some of the specific areas of spending that are relevant to the members of this committee. But I believe Dan Pollock from DHS is on the meeting to talk about questions related to the at-risk work group. Laura Kramer, who is an MMB staff person but currently redeployed to work with the food security work group, is also here. And we also have Margaret Kelly and Angela Vogt, who are working on the MDH side, particularly on testing, but also critical care supplies if there are questions there. And then I also have Amy Jorgensen with me today. She is our head of the COVID Response Accountability Office at MMB, really focusing on the local government allocations from the Coronavirus Relief Fund, but also just managing all the federal guidance and the administration of that fund as well.
Yeah,
so
that's
happy.
right. That's perfect. Yeah. And so members, we have a very august group of folks on the call here to help you answer any questions you have about how we spent $2 billion. And actually some of the state money as well is also part of this discussion. So if you have a question, now is a good time. And if I don't see your hand, just pipe up. Really?
Mr. Chair, if I might highlight one more
No, you
item.
better highlight something. They're all so pleased with the way you spent. I think they thought you spent the money perfectly. They couldn't have had a better thought. So.
I did want to flag, I checked our reports on the Coronavirus Relief Fund this morning, and just to highlight how quickly these numbers can change. Another $40 million went out the door to schools between yesterday and today. So if you're looking at the report that was sent to you yesterday, showing the unspent money for schools, an additional $40 million has gone out the door today.
Okay, well, then I'll ask you a question, just conceptually. You know, $2 billion is a lot of money. And then the state gave, what, more than 500 million. How much did the state put in cash? Do you remember, Ms. Raitan? 700 million or something, wasn't it?
In terms of the fund, are you speaking to the funds to local governments, or are you?
No, the state kicked in some cash from our money, and the feds kicked in 2 billion.
Yeah, so the Coronavirus Relief Fund, Mr. Chair, is entirely federal dollars. The state put 200 million into the COVID Minnesota Fund, which was a flexible pot of money to respond, but there was also specific state appropriations, excuse me, back in March that totaled approximately 550 million.
Right.
That includes that 200. So there was an initial state effort back in March totaling about 550 million, which is inclusive of the 200.
The 200 is included in that.
That's right.
Okay. And so when the dust settles, is there going to be a way to look at the equivalent of like $3 billion almost and see, well, 2.5 billion, and see what did we really get for it? You know, what was there going to be like a look back? It went out the door quickly, and I'm not doubting the integrity of the groups that got it, but you know, what would it have been if we wouldn't have done it? Is there going to be a retro review just to see? Because it seemed like it went out pretty fast, and here's $1 million. And even when we did some of our human services stuff with our small pots of money, we guessed wrong pretty badly on like the nursing home uptake, and you know, and some of the quarantine shelter needs and so on. Is there going to be some kind of way to look back?
If Amy Jorgensen can speak to the reporting requirements, that might be a helpful component.
Oh, sure. That'd be perfect.
Sure.
Welcome.
Good morning, everybody. Mr. Chair, Madam Chair, thanks, Britta. So we're in the midst right now of compiling quite a few reports, both for the federal government, and then we also provide quite a few reports to you both on the CRF and the Minnesota COVID-19 Fund that show how things were allocated. The federal reporting that we're working on, the first of which is due on December 15th, will provide a very detailed look at all of the expenditures down to the purchase order contract grant level. And so there will be quite a bit of information that will be available both to the U.S. Treasury and then to you as well. And then we'll just continue to keep reporting those expenditures again in a very granular, detailed level, so you'll be able to see everything very clearly. We also do have our transparency site on the MMB website that goes down to that level as well, where you can see down to the dollar what was spent in each of the different appropriations.
Thanks. Another county is going to report what they did with their money as well in some way.
Mr. Chair, yes. So we do receive reports from the local governments. We're actually waiting on the final reports from the counties right now to see what kind of money they're going to be turning back to us. And they have to report their expenditures in the 18 federal categories that have been defined. So it'll be a pretty granular look at the county, city, and town level as well.
And then if there's money, and Senator Wickland, you're on deck here. So, but if there's, let's say you get back $50 million from the county, it's then in the purview of the LAC or the governor just to pass it out somewhere else to do.
Mr. Chair, it's my understanding that one of the special sessions, you all passed some legislation to say what the disposition of those funds have to be. And I believe, Britta, you can correct me if I'm wrong, but I believe it has to go back to the general fund.
Oh, so it's going to supplant whatever general fund was there. Oh, I see. Okay, that's actually a good plan. Ms. Wright, do you want to say that again?
Yeah, Mr.
I want to hear
Chair.
that twice. That'll be great.
Mr. Chair and members, yes, that was part of the October special session agreement, that any money coming back from the local units of government, we will find eligible state expenditures from that early 550 million. and redirect them to the Coronavirus Relief Fund to make sure we use up those dollars and then make a cancellation to the general fund.
And is that going to then be added into the state open-ended fund, or is it going to go just to the general fund and be done?
It will just go to the bottom line of the general fund, and we will reflect that in our February forecast once those transactions have happened.
Well, that's actually helpful news. You learn something at these meetings. Senator Wickland, nice to see you again.
Thank you, Mr. Chair. I guess the slide may have answered the question, but I guess just in more detail about the spending by the end of the year. So all of the numbers that are unexpended or unencumbered, do those need to be encumbered or expended by December 31st? Or is there some other timeline for that?
Ms. Jorgensen or right hand, whichever.
I can jump in first. Senator, we do need to have eligible expenditures occurring by the end of this month. And what we will be doing over these next couple weeks, and we are kind of in this intense time period of evaluating spending in each of these allocations, we will be determining if we're waiting on invoices. In a lot of places, we're waiting to be invoiced for some of the expenditures that have already been incurred. So the spending isn't showing because we haven't received an invoice yet. In other cases, we need to hear back from grantees to find out how much they have spent. But at the end of the day, we will be coming back probably middle of next week to the LAC to be talking about how we make sure we use every dollar of the Coronavirus Relief Fund. So where there is in fact underspending from the allocations, we can repoint it to general fund dollars.
And that accounting has to happen, that accounting has to happen before December 30th or something at the state level. You make a judgment and then you can just kind of fix it up later.
I have a barking dog, so I'm going to ask Amy to respond.
Mr. Chair, members, so the rule with the Coronavirus Relief Fund specifically is that the costs have to be incurred before December 30th. But we do have a period of time where we can do the accounting work. So as Ms. Rattan talked about, we are still waiting on invoices from a number of places. We also have grantees who are not required to report their expenditures until January. And so the Treasury has recognized that with large pots of money like this, with the Coronavirus Relief Fund in particular, that it's going to take some time to do a full accounting. So in general, they're hoping that we can kind of clean up the accounting within 90 days, so by the end of March, but they are actually keeping reporting open through September 30th with a due date of October 12th of 2021 to do the final accounting. And I think that's to account for things like FEMA reimbursements, insurance reimbursements, things like that might take a little bit longer time. So the rule is incurred by December 30th, and then we can do some accounting work afterwards.
So Senator Wickland, did that get you where you wanted to get? Do you have any more questions?
Yeah, no, that answers my question. It looks like a challenging period the last 2 weeks of the month.
Oh, yeah. But... Well, and I want to commend all the agencies that are sitting here looking at us today and the way that they've shifted gears. And it's been a tremendous amount of work. Nobody counted on this. You thought you were going to be doing, some math, worrying about funding of nursing homes or something. And now you're all been redeployed to fight a fight. This is the last call for questions from members to this crew that's in front of us here. And if I don't see you unmute, or just say something if you want. Otherwise, it's like an auction, going once, going twice. Well, thank you very much. And I know if members have other questions that your various agencies will be happy to reply to us. And Mr. Pollack, sorry, I had no reason to bring you before the committee today. So we'll get you again, though. Don't worry. And Ms. Kelly, thanks for being there too. Okay, so let's continue on with our last item, which is the maintenance of effort with Mr. Anderson, and so welcome back.
Thank you, Mr. Chair. Appreciate it. Good morning or now afternoon, everyone. My name is Matt Anderson. I serve as the Assistant Commissioner for Healthcare and State Medicaid Director at the Minnesota Department of Human Services. Appreciate the opportunity to be with you and look forward to answering your questions to the best of my ability. And when that fails, turning to my colleagues and subject matter experts from DHS to help me out.
We already have covered the topic, so if you just want to fill in the gaps.
Yeah, so I think the most important gap I'd like to fill in is that while we talked about the maintenance of effort and particularly continuous coverage policy for getting the enhanced FMAP, it's important to at the outset to put the discussion in the context of the COVID-19 epidemic, and that the continuous coverage policy also has a public health component, and that is that during the epidemic, my health, my family's health depends directly on the health of my neighbor. And if my neighbor can't get tested or treated for COVID because they are uninsured or worried about the costs of that care, that then jeopardizes their health and their family's health, but it also jeopardizes the health of their neighbors and their community because of the spread of the infection. So maintaining the continuous coverage has financial benefits for the state and the other maintenance of effort requirements to be able to get the enhanced FMAP. But I wanted to just impress upon the committee that it also is important that we maintain coverage for people so that they are able to get the care they need when access to that care is more important than ever. The other thing I would point out is in the materials that we provided, we are seeing Mr. Chair, you referenced earlier about impacts on enrollment and applications. We have charts in there reflecting the changes in enrollments we've seen this year. You'll see that overall enrollment in our healthcare programs is up by 100,000 people since the beginning of the year. And as you would expect, that enrollment really took off with the sort of one-time shot that our economy took, and the beginning of job losses for people like that lost employer-sponsored insurance. We also included information for comparative purposes to the Great Recession. And you'll see that our rate of growth in enrollment isn't staggeringly different than what we saw during the Great Recession, even though, again, the job losses during the Great Recession were stretched out over a longer period of time. And that is most likely due to the fact that when people lose employer-sponsored coverage, when they lose their jobs, they don't immediately enroll in public programs. They wait as long as they possibly can, often in the ranks of the uninsured, until they have a medical episode where they really need care urgently and they can't avoid it. And then it's with social workers, our partners in the counties and tribal nations, the healthcare delivery system that come into that person's life and help them get enrolled in coverage that they're eligible for. And so when we see that growth in enrollment continuing to increase, it's really catching up, we think, likely catching up to those who have been uninsured but are now experiencing health conditions. Conversely, the number of applications we're getting is below what it was in 2019. And again, the charts that you have, the blue line is 2019, the green line is 2020 for comparison. And this is reflecting the impact of that continuous coverage policy. That what you'll see is week over week, we have a lot of people in what would be a normal year who lose coverage. Their eligibility period ended, they didn't turn in some paperwork, they didn't get an assessment they needed, whatever it may be, but we're still technically eligible. And so what ends up happening is they lose eligibility and then have to reapply later to get back on the program. And so the statistics that we're showing pretty remarkably consistently week over week are showing that gap, which is reflecting the number of people who don't have to reapply because they're maintaining their coverage. And so as we look at lessons learned from the pandemic, one of the lessons is that there is a chunk of our enrollees who are losing coverage that they would be eligible for. And if there's a way that we can identify them and keep them covered, we will reduce both them falling into the ranks of the uninsured, but also some of that administrative burden in the churn. Finally, the last point I'll make in the interest of time is just to note that the decisions that the state has made to comply with the maintenance of effort requirements are not different than the decisions made by every other state in the country. Every state has adjusted its programs to meet the maintenance of effort requirements and obtain the enhanced FMAP in the same manner that the state has done. So with that, I'll close my comments, but I really would be happy to answer questions about the maintenance of effort, the enhanced FMAP, or the changes that we've made to make sure that our enrollees maintain access to care during this difficult time.
Thank you. Any questions from members? We just have one more topic, and that's the TANF one, I think, after this. Here's the auction, going once, going twice. I appreciate that. I think we've covered it pretty thoroughly. And I don't know who's doing the TANF part. Is that Mr. Albrecht or somebody from the department? Was that on the agenda? I know I wanted to talk about it. There was a handout about it. So,
Mr. Chair, this is Brittany. It's not an agenda item. I do have the handout that the Department of Human Services provided. I don't know if Mr. Greenman's available to walk through it, but I can certainly share it on my screen.
Yeah, okay, yeah. I would like just to walk through that briefly, just for all kinds of reasons. Mr. Greenman and then Mr. Albrecht is also conversant about it, but and you just like to work under pressure, Mr. Greenman. It's
Oh, right. This is showing the TANF fund balance based on the November forecast. Sorry, I was
that's
confused, okay, which is normal for me.
And this is one of the attachments in the hearing agenda as well for people. Oh, there it is in front of us.
Okay.
And so what I'm interested in knowing is, I'll just tell you what my interest is, and then other members might have questions. You want MFIP to work, and if you look at the reasons for the TANF fund, it's for provide assistance to needy families, independence by getting jobs, work, and marriage, reducing out-of-wedlock pregnancies, and encouraging two-parent families. And it seems like we're not doing very well at some of those. And my interest is in examining this area a little bit and see if there's some way we can find a way to make it be more functional. Surprisingly, there's a bit of a surplus, so that could be maybe spent in a way to make it actually do what it's supposed to do, especially with the effects of COVID that are going to be upon a lot of these families. So, but anything you want to say about it, Mr. Greenman, is fine. And I have a question after you finish whatever you're going to say.
Sure, Mr. Chair. As you can see, the fund balance at the end of fiscal year 25 is $71 million. And there's two main reasons for the balance being larger or being significantly larger than it has in the past. One is the item I mentioned earlier when I was going through the forecast, where I talked about people being put on immediately on a state-only funded program rather than a TANF funded program when we had the executive order waiver to bypass the diversionary work program, and those people are going to be put back on the TANF funded program to the extent they're eligible once early in 2021. The second item has to do with our maintenance of effort requirement in order to receive the TANF block grant. We have the authority to count expenditures related to MFIP, childcare assistance, things like the working family tax credit and Head Start. However, our ability to count those expenditures in some cases is capped. For example, the working family tax credit and the Head Start amount are capped. What happened is we used childcare to general fund expenditures for childcare to meet our TANF MOE requirement, and we've had a significant reduction in childcare enrollment, partly due to the COVID-19 pandemic. And as a result, we've had to spend more general fund money through the MFIP program to meet our maintenance of effort requirement. When we spend more general fund on MFIP, we spend less TANF on MFIP. And so we've got a growth in the program, or a growth in the fund balance.
That's really interesting. And so, not for now, but it would be interesting to see how much, like, what the MOE is and what of that is available for being expended. There's the proposal to spend $500 per unit, a family unit for $15 million. Is there enough MOE available to even do that? In the latest, there's a proposal drifting around for that in this special session, for instance.
The MOE is set by the federal government, and it's essentially $172 million a year that has to count of general fund spending that has to count against the MOE, and we reach that every year through our MFIP spending, and then also through our child care assistance program spending and the other pieces. We could use more of the working family tax credit expenditures, the general fund expenditures on the working family tax credit to meet the MOE. There is a long-standing, in the appropriations article of the finance bill, there's long-standing language that limits the amount of working family tax credit that can be used, but we could certainly do that. I'm not sure if that answers your question or not.
No, I appreciate it. And so this is just the beginning of a discussion. And just as we're looking, from my point as the chair of the Human Services side, I want to look at everything we can look at to make it work better and to be effective. And sometimes you have a crisis, you decide, well, as Commissioner Malcolm was mentioning, there's all these interrelationships which don't come to be visible until you get to a time of crisis. And so on the TANF side, which has not been an area that Republicans traditionally weigh into to make it more effective, I'm interested in doing that in a bipartisan way with our committee to see if we can come up with some leadership on that. It may be impractical, but I know if you're going to try to find some ways to find some of the TANF families that are stuck, you may need a way to provide some interim services to get them over the hump into independence, much as we've been doing with the people with disabilities. And so if there's 10, 15, $20 million available, if we could find a way to spend it well and actually get have it be truly productive to accomplish the goals, I think that'd be great. If the money's all tied up because we have to spend $1 of general fund to get another $1 of TANF available, that's going to be really problematic. But maybe we'll decide that's a good way to spend some of our very limited funds. So that's my interest, and I'm just announcing that now as a thought. It just came up, especially in the discussion about the $500 per family question, if that goes forward or not. And I was a co-author, I think, on that bill at one point, and now I'm kind of getting cold feet about that, thinking that if we could find a way to take that 15 and leverage it into families in a way that's truly meaningful, we might actually be pretty happy about that. So anyway, that's my TANF thoughts, and I'll open it to questions from anybody from the committee if you want to talk about that. And this is our last item, just so you know. Okay. But if this were to go forward, it would require quite a collaborative effort, and I would be inviting a few of my friends from each side of the aisle to help me sort this through. And a couple of those are at this meeting right here. So, Commissioner, I don't know if you're around. I was going to offer you a chance to say goodbye if you want. If you wanted to have a final word, and then I'll say goodbye myself. So, go ahead, Commissioner. The floor is yours for anything you want to say.
Just thank you, Mr. Chair and Madam Chair, for your time, and committee members. Thank you for spending the time to pay attention to our forecast and get an idea of what we're in for in the next session, and to listen to some of the things we've talked about today. So always grateful for the time. Thanks a lot.
Yeah. And let me, anybody else want to say anything before I say goodbye? Okay, so I hope the people watching this hearing today have been as impressed as I have been with the caliber of the staff who has weighed in at so many different angles. We've heard from close to a dozen different staffers from many agencies today as they've been discussing what they've been working on, and I am forever just impressed with their level of knowledge, their professionalism, their commitment to the purpose of serving the people of Minnesota in so many ways, and still trying to be, productive and frugal with the money that they know is so dear. And I hope people recognize that. And I want to thank the two commissioners for coming forward and their commitment and how their job has gotten so much larger than they thought, and the staff of mine that has been behind the scenes, and for the attendance of everybody who's here as members. I think we covered a lot of ground. I think we've set the stage well for an understanding of the budget. I do urge people again to read this thing. It's just that productive. And so that's it for the HSR committee for this year, I believe, unless something comes up, and I'm not afraid to call a meeting if something does come up. And if you think we need one as a member, let me know. It sounds like Senator Benson's committee will be doing some more work yet this year. So short of that, thank you for your good attendance. And with that, how do you have a virtual gavel? So I'll hit the air. We're adjourned. Thank you very much.